A very warm good morning to everyone present here. I would like to welcome you all to this CME on point of care testing. Now, before I begin this topic, I would just like to see a raise of hands if, like, for how many of you this term, this topic, POCT, is a very new term? Like our Dean sir said that he just heard this term like before coming. Is there anyone, to whom this topic is completely new or have never heard of it? Okay, so today, before I begin, first of all, I would like to make a disclaimer here that whatever equipment and devices that will be displayed throughout this presentation is completely intended just for the educational and illustrative purpose only, and we do not endorse any specific brand or manufacturer during the presentation. So today, in the next few minutes or an hour, I would say, we will be exploring about what is POCT, its evolution and its scope, its advantages, its disadvantages, and the challenges that are associated with the POCT devices, the guidelines to be followed to operate the POCT, the quality consideration, and we will review some commonly used devices from the biochemical perspective. Now, traditionally, if we look that the laboratory testing involves a multiple step process, which includes, whenever a patient comes to the doctor requests certain investigation, and then it involves a multi-step process that includes collecting the sample from that patient at the bedside, at the OPD or the lab. Then we transport the sample to the centralized laboratory. And most of the time, this lab is at a distance, right? Whenever from emergency to the lab or from the ward. And sometimes we have to send the sample to somewhere outside. We have to outsource this sample. Once we transport this sample, then the sample is registered, we prepare the sample, and there are multiple steps associated with the analysis. We have to run the quality control. We have to validate whether our test results are accurate or not. And then we report it. That report is transmitted to the patient, and then the patient takes that report back to the doctor. So this overall process from the time the physician requests the sample till the patient goes back with the report to the physician is known as turnaround time. So turnaround time refers to the total time taken to complete a process or a task. And when we talk about in the medical perspective, we call it as therapeutic turnaround time. So the medical staff, the recent advances has engaged in increasingly use of point of care testing to actually reduce this therapeutic turnaround time. So through numerous proven application, point of care testing has quickly procedures which provides quick test results and improve the therapeutic decision making, thus reducing the economic burden of the overall health system. Now, point of care testing addresses this challenge of increasing the turnaround time by bringing the laboratory close to the patient. There are portable and handheld testing devices which enables the healthcare workers to perform the rapid test on the samples, significantly reducing the time needed for medical decision making. So the diagnostic testing, which is conducted at or near the site of the patient care with the goal of immediate result that can be used for rapid clinical decision making. And this will ultimately improve the linkage between the diagnostic testing and the therapeutic intervention. So with emerging technologies, innovation in the healthcare like, smartphones, biosensors, lab on a chip, and wearable devices, point of care technologies are quickly becoming the part of the transformation of healthcare landscape. Now, before we dive into the topic of point of care testing, let's look at the difference between the central lab and the point of care testing setup. So we all know that the central lab is on site. It is immobile. The lab is there and the sample goes to the lab, so it's on site. But point of care testing setup can be developed at multiple setup at anywhere, like in bedside of the patient, the emergency department, the ICU setup. And here in central lab, if we see, there are limited instruments to perform the bulk of analysis. We use a huge, large clinical automated instrument to analyze, but here POCT involves multiple devices. And in central lab, there are limited staff with focus on the sample analysis, but here there are multiple staffs with focus on the patient care. Point of care testing is basically focusing on the care of the patient, and staff with the laboratory training and experience comes under the central laboratory, but staff with the clinical training and not laboratory education, they are also able to run the test in this point of care testing devices. Now, if we look at the history, interestingly, it comes back to the 14th century, where a Greek physician is actually observing at the color of the urine to make the diagnosis in the patient. And the breakthrough in the testing was when pregnancy was able to be detected in the urine. And this is a photograph which is taken back from the year 1826, where we can see here, although it's not visible, this is a physician, this is a doctor who is holding a test tube, and the test tube has a faint picture of a baby, just for the illustration. And here is a mother who is scolding her daughter that she's pregnant. How can she be pregnant? And here we can see a guy hiding behind the doors. So it all started, the pregnancy test in the urine started back in 1826. And this test was actually a breakthrough in the history. And also, there is certain charts that are here. We can see here the urine glass disc was used as a colorimetric standard, and the first one known to date was dated back in 1400. So back then also there were charts, color charts, to compare the color of the urine with what the patient were being tested for. So if we look at the key milestone in the POCT here, as already mentioned, Egyptian and the Greeks used the sight, the smell, even the taste of the urine for analysis. And in 19th century, the simple color change, like chemical reactions in the urine for glucose and protein at the bedside of the patient, were performed. And here, near patient concept, that early ideas for bringing the lab test closer to the patient, it all started in the year 1950s. And when we look at the main evolution of the point of care testing, the term point of care testing was coined by the doctor Gerald Post, who coined this term while he was performing biosensor-based serial measurement of ionized calcium in the whole blood at the bedside of the patient undergoing hepatic transplantation. Now, he was developing technique where he was testing for ionized calcium in the patient who were going hepatic transplantation surgery. And during transfusion, it was very necessary to monitor the calcium level of that patient who was undergoing surgery. So he developed a technique by which the test, ionized calcium test, could be tested in the blood, whole blood itself, in the operation theater itself. And he was the one who later even coined the term point of care testing. And with the recent advances, we can see that in the year 1995, the standardization of the point of care testing was done. And it was the same year that even the rapid diagnostic kits for HIV and infectious disease was initiated in the year 1995. And here in the year 2000, we can see that the small variable point of care testing devices were used. And we all saw the major transformation happening in the COVID era, where people used to go in lines with the booth being for sample collection, but later the testing was made available at the home itself, where the patient can, him or herself, get the testing done to detect whether he has or not the COVID infection, right? So this has been the breakthrough, and cutting-edge POCT integrates microneedles and microfluidics for improved comfort, speed, and accuracy for the patient testing. So how do we define point of care testing? We already talked about what is POCT, an overview, and the history. So there are certain definitions given by the College of American Pathologists and the World Health Organization. And here the CAP defines POCT as tests designed to be used at or near the site where the patient is located. Number one point, the patient at or where the patient is located. Number two, that do not require permanent dedicated space. So it does not need a dedicated room like we need it in the central laboratory setup, and that are performed outside the physical facilities of clinical laboratories. So it's happening outside of the clinical lab. And WHO definition also emphasize on the conventional here, with the goal of immediate results to support the clinical decisions for the patient, improved patient clinical outcome. So any test which is done at the patient site outside the laboratory, which does not require a dedicated space, and with an ultimate goal to improve the patient outcome, to enhance the clinical decision, is the definition of point of care testing. And there are various names for the point of care testing devices, as we can see here. Based on the location-based name, we can see the name as the satellite testing, near patient testing, bedside testing, physician office testing, extra laboratory testing, offsite testing, or kiosk. It's a Turkish word. It means like a separate shell from which we can get the newspaper. So in that similar shell-like format, it can be called as these. And based on the user focus, we call it as patient focus testing, decentralized testing, peripheral testing, and also self-testing, because we all have seen that it is used by many patients to monitor the blood glucose at the home by themselves as well. So when it comes to the point of care testing, WHO emphasizes on four key attributes of healthcare. One is accessibility, second is affordability, third is accuracy, and the fourth is timeliness. So when it comes to the point of care testing, healthcare should be readily available to all. So the point of care testing device should actually be easily available to all. And the cost should be manageable for everyone. If the cost is very heavy, not everyone can use the POCT devices. It should be accurate. It should give us accurate health information, and treatment must be correct based on the results provided by the POCT devices. And healthcare should be provided promptly when needed. So based on the results, which is made available very promptly, the clinical decision is enhanced, which should be promptly leading to the improved health outcome in the patient. And WHO supports the assured criteria when it comes to the point of care testing. And here are some of the points here. Here we can see A stands for affordability. S for sensitive. The test should be sensitive. It should be specific. It should be user-friendly. It should be rapid and robust. It should be equipment-free or with minimal equipment requirement. And it should be deliverable to all the end users, that's to all the physicians and all the healthcare provider and the patients. So based on what we have studied so far, here are the ubiquitous feature of point of care testing. It should be simple. That is, it should be simple to operate. It should be durable. The reagents and the consumables should withstand the storage and use. We cannot have we should not be, it's not possible if we need a sophisticated storage technique for a device. If the device is very simple, but we need a very sophisticated technique for the reagent storage, it does not fulfill the criteria for POCT. So it should be very durable. It should give us accurate results, and the testing should ensure the user safety as well. So the scope of POCT device, if we see here, it is described in the CCU, ICU. It can be described in the surgical ward, in the operation theater, in the emergency department, in the pediatric units, in clinics, in physician, in offices, in nursing homes, even at the ambulance for monitoring patient who are at the acute stage. And when we use POCT in the primary healthcare, it helps in the rapid diagnosis and to determine the appropriateness of the triage to the secondary health. So the multifaceted role of POCT in healthcare is the role as in the rapid decision making, in the critical care, and in the resource limited settings like primary healthcare as well. So here are various advantages of POCT. Why do we want to use POCT? So here, first is the quick turnaround time. As I already mentioned, turnaround time. So turnaround time is faster when we use the POCT devices. Definitely, it improves the patient outcome and the cost of the overall patient care and patient satisfaction, because the patient is getting the reports very easily, very fast, and the treatment is initiated very sooner, so the patient is satisfied. We need very minimal sample volume. So especially for neonates, for pediatric population, where getting the sample is very difficult, POCT involves minimal sample volume requirement. And here we can see decentralized testing is there, especially valuable in ICUs, in the emergency department, in the remote healthcare settings. There is reduction in the administrative work and decreased manpower as well. We do not need a lot of paperwork for the POCT devices, and it is fitting the modern fast-paced life, because everyone wants to get things done quickly. They don't have time to wait, come to the hospital multiple times to get their reports. So it is fitting the fast-paced modern world, and less training is required to operate the point-of-care testing, and it has a reduced pre-analytical error. So I will be talking about pre-analytical phase and the error in some time. So here, because we are directly testing the sample in the device, so that there is less chance of sample mislabeling or delays. But there is not just the advantage that comes with POCT, there are certain disadvantages that comes. Whatever were the advantages might also lead to disadvantage, like it is difficulty. As we saw with POCT, the advantage was less documentation and paperwork needed. But again, the disadvantages is that because there is less documentation, there is difficulty with the documentation of the test results, billing, and regulation compliance. And more expensive POCT, because we are using a single held cartridges and disposable cartridges, which leads to the higher cost of POCT. There is inter-individual variability higher in POCT because everyone can use the POCT device, right? We see for glucose monitoring, everyone is using the device at their home. Are they well trained enough? Do they know the manual? Have they read the procedural manual? So all these variability does exist, and that is as an disadvantage, because this leads to the discordance with the report. And there is maintenance of the queues, quality control and quality assurance is difficulty, as anyone can use the POCT device here. And the central laboratory test results and POCT results are not always comparable. So this thing we need to be very aware. You know, sometimes the patient comes, they have done their glucose testing with a glucometer, and they come and do their testing immediately after some time in the central lab, and they see that there is a variation in the test report. And they might say that, okay, the lab is not giving me a proper report. We should not be trusting the lab, but we need to understand why these variability exists. So when we are doing the glucose testing with a glucometer, we are doing the capillary testing. And in the capillary testing, the postprandial blood glucose level is slightly higher when compared to the venous blood. So as a person who is guiding the patient, we need to know this difference. Otherwise, patient will lose trust on us, that they think that the lab is not giving an accurate report. So this variation, this differences in the specimen type, the technology, the interfering substances should be aware to everyone who is using the POCT devices and also to all the laboratory personnel, so that they are able to justify any variation that comes with using of the POCT devices. And here we can see the pre-analytical and post-analytical issue are not easily recognizable if the tests are used by the untrained staff. So here are certain disadvantages that comes with the using of the POCT devices. So based on these advantages and disadvantages, there are certain limitations to use the certain challenges that we face when we use point-of-care testing devices. Number one is, as I mentioned earlier, accuracy and analytical performance, because it's often lower compared to the central laboratory testing, because point-of-care testing device is basically prioritizing the rapid results and ease of use. So they often use simple methodology compared to the sophisticated central laboratory instruments. So the results are definitely lower, often lower compared to the central laboratory testing. And there is, as mentioned earlier, there is operator-dependent variability, and there is limited test menu. We cannot perform all the tests that we want in the POCT devices. So we have limited test menu. And as I mentioned earlier, the challenge is high cost test, because we are using the cartridge, which are single test use and which are difficult. So despite the faster turnaround time, we know that it's expensive. And here is a point on quality control and regulatory compliance. I don't know why the slides are completely visible on my, but here it's showing incomplete slide. So when we talk about quality control and regulatory compliance, ensuring consistency in the quality and meeting regulatory standards can be challenging. So when we are using POCT devices, strictly adhering to the QC guideline or quality assurance guideline might be difficult. So here, let's know what are the basic laboratory regulation or guideline that needs to be followed. So when it comes to point of care testing devices, the standard that it follows is ISO 22000-22870, which was established in the year 2006 in association with ISO 15189. And when it comes to the Western country, they follow this Clinical Laboratory Improvement Amendment 1988, that is CLIA guideline. And in Nepal and India, we adhere to the National Accreditation Board for Testing and Collaboration Laboratory, the NABL. So the quality control process in POCT, the test should be categorized under these CLIA regulation. So the CLIA has categorized the POCT testing, and the test complexity has been assigned as waived test and non-waived test. We will be seeing what these tests are in next few slides. And we have to strictly, the specific quality standards are applied to the non-waived test that needs to be followed, and the frequency, how often should be performed the quality control on the POCT device should be strictly followed, which is determined by the test complexity and the guidelines that are provided, and detailed records should be maintained for the QC process, because point of care testing devices are small, handheld, it does not have a proper record keeping process. So it's mandatory that everyone who is using the POCT device should be recording all the records of the QC steps that they are performing on the test. So these are the 5 levels of certificates that any labs which are performing POCT should have. So there is certificate of waiver, which should be issued to a lab which just perform waived test. I will be coming to in the next slide what is waived test. And there is certificate of registration. So as I mentioned, there is a waived test based on the complexity, waived and non-waived test. And non-waived tests, they are moderately complex and highly complex tests. They should have this certificate of registration. For lab which performs test on the microscopic based procedure, they should have the certificate for MPS. And the certificate of compliance is given to the lab, which when they are inspected, they are in compliance with the CLIA requirement, and certificate of accreditation is given by a higher body, here, as we can see, by the Healthcare and Finance Administration. So let's see the test based on the POCT complexity. They are waved tests. Wave tests are simple tests which are very simple to perform, and they are very subject to regulation. Very less chance of error happening with those tests. So wave tests are simple tests like dipstick tests. We dip the strip in the urine and we compare the color. There is very less chance that there is any error going to happen in that step. So, or a UPT, urine pregnancy kit test. So these tests, which are very easy to perform, anyone can perform in the home. We call it as wave tests. And non-wave tests, they have to strictly adhere to the quality assurance and quality control guidelines. They have to qualify the personal qualification, proficiency testing, and inspection. And here, in non-wave testing, there are two major categories. One is the moderately complex and the other is the highly complex. And majority, 75% of the non-wave tests, they falls under this moderately complex category. So there is another categorization based on the sample type, whether we are using the capillary sample, whether we are using venous sample, or we are using the arterial sample, and types based on the parameters, biochemistry tests, the device which performs the biochemistry test, for hematological testing like PT-INR, for infectious disease testing, we can see rapid tests like HIV, malaria, and for urine analysis testing. So this is how we classify the types of POCT. That was based on the complexity that we categorized as waved and non-waved. And based on the types, we can see we have single-use POCT device, which is very simple, which is handheld devices, and it is basically qualitative in nature. It's a strip, it is a cartridge, it is just the strip that we do, the cartridge that we use for the UPT test. It is very simple, and anyone can perform this test anywhere. So it comes basically under the waved test category. And when we look at the multiple use quantitative cartridge based devices, they are larger. They can be single or multiple use, and mainly they are quantitative. They provide a quantitative a value to a certain analytes that we are testing with. So this is the devices that we are using. So here we can see the example, single-use qualitative or semi-quantitative cartridge strip as urine dipstick or beta-HCG in UPT. And here we can see glucose is also used in the strip. So it is also simple single-use quantitative cartridge device. And here multiple-use quantitative cartridge and benchtop devices are mainly for the ABG analyzer in the emergency setup. In the ICU setup, we can see these devices, which is used to measure the pH, blood gases, electrolytes, and other metabolites. And here are the various testing principles. Their different instrument is based on different principle of testing. So basically reflectance principle, it is based on electrochemical chemistry principle and lateral flow immunoassay. So here we can see the testing modalities, which are basically the qualitative or semi-quantitative strips, which is used for the urine strip. So in emergency, if we go, we do a qualitative troponin I assay, where we get 2 lines and we say the patient has troponin positive as a result. Here, there are immunoassay-based POCT testing modalities, which uses the direct or the competitive immunoassay techniques, which is used to detect the pathogen, the drugs, or protein in the sample. There are antigen-based testing, and there are also molecular testing. As we can see that it uses the PCR technique, the RT-PCR technique to perform the test. Now, coming to the POCT processes stage, when we look at specimen requirement and procedure, whenever, like when we discussed about the turnaround time, there were 3, the entire process, is divided into three different phases: the pre-analytical phase, the analytical phase, and the post-analytical phase. So here, if we see the pre-analytical phase, the pre-analytical phase occurs before running the sample in the POCT device. So the sample collection, the sample transport, the sample storage, everything comes under the pre-analytical phase. Here, there is a maximum chance of error happening in this particular phase. An analytical phase is the next step where the actual testing is done and in the device. So here the POCT, the test is being conducted in the analytical phase, and the post-analytical phase is the phase when the testing is complete and we obtain a result, and the result is that then communicated for the treatment through the electronic medical record or written or verbal instruction directly to the treatment team. So the post-analytical phase is once the report is there in the machine till we give that report to the treatment team, and that stage is known as the post-analytical phase. So here first if we see here first, the sample is collected for analysis and the sample is prepared, and then the sample is applied to the device, then the test is run and the result is transported. So this is the overall process that is associated with the POCT device. So how do we ensure that we are getting an accurate testing in the POCT device? Because it is very important. We can see that it is helping with the decision making for the patient. So we have to ensure that the reports that is generated is accurate. And for that, what we need to know is every device that we are using, they varies based on the specific manufacturer, the sample type, the device, the principle, the procedure is different for each device. So it is very important for accurate results. The setting up, and first thing we have to do is we have to set up and calibrate the instrument properly before we are using. And the next thing is we have to follow the manufacturer instruction for use. The guidelines, the manufacturer leaflet that has been provided, everyone who is using that device should have a sound knowledge in this MIFU package, which is crucial in achieving accurate sample preparation and testing. And finally, whatever strip or cartridge that we are using, we need to check with the dates. So we need to check the date stamps, and we should make sure that the expiry cartridges or reagents should not be used. In this way, we can ensure the overall point of care testing device. So as we can see, the specimen handling plays a very important role with any POCT devices. So here, the pre-analytical phase of the specimen collection and handling is crucial. So we need to adhere to the personal regulation, appropriately preparing the patient and specimen collection container. We cannot take the sample in any container that we want to. There is a specific container designed for specific analytes. For example, if you want to do a ABG testing, you have to make sure that your vial or your syringe is heparinized. If you do not heparinize the syringe and draw the arterial blood gas, your reports are not going to come accurate, right? So we need to adhere to the description for the sample collection. And the next point is the patient preparation as well. You know, what are the things that we need to keep in mind when we are doing POCT testing? Suppose some patients are taking certain vitamin supplement like biotin. These might interfere with the glucose studies in the testing POCT devices. So these all things should be kept in mind. How are we storing the reagents? How are we storing the cartridge? The testing devices is also very crucial. And are we documenting the procedures that we are doing, the QC properly? This is also very mandatory. Now, once we run the test, how do we respond to the POCT results? So there is one thing known as urgent or stat test. So this urgent or stat test comes to the lab. The person, the physician or the doctor who is looking at the patient based on the severity, they write the test as urgent or stat. Stat means you want the test results to be done immediately and provided back with the results. So this is based on the person seeing the results, and the lab will provide critical value. Critical value is the value which which significantly deviates from the established normal range, irrespective of the patient condition. So we will be, as a POCT, the lab running the POCT device or the person running the POCT test will be checking at this critical value, which is provided in the leaflet as well. Now, coming to the error, we need to be able to identify the potential area of error in the POCT when we are running the POCT. First, due to the portable nature of the POCT, the reagents, the test, and the samples are often exposed to conditions that may differ from those that are there in the central laboratory setup. It's like humidity, temperature, time to be tested, all can be fluctuated. So number two is the interfering factors. The pre-analytical errors phase should be identified before running. So the errors are the errors associated with the patient identification and in the specimen identification, collection, handling, transporting. And specifically because we are measuring the sample mostly in the whole blood, it's very difficult for us to know whether the sample is hemolyzed or not, because we are directly providing the whole blood sample to the device. So certain parameters like potassium in the whole blood sample, they are deranged. Okay, we need to know this. So sample collection is very important. So these area of error should be identified. When it comes to analytical phase error, we need to know the interfering substances. We need to know the patient-related factors that might lead to errors, like whether the patient has icterus, jaundice, lipemia. These all affect the quality of the reporting. And visual inspection will also give us a guide. If the sample is if we are separating the serum and if we see a very yellowish color sample, we know that the patient has a icteric, like a light yellow color sample, icteric jaundice can be suspected in that sample. If the patient has a turbidity in the serum, we can say that the sample is lipemic. So all these sources of error should be the person conducting the POCT test should be able to identify. They should be aware of these potential sources of error, and the corrective action should be taken accordingly. So when it comes to the quality assurance, we want to make sure that the test that is given, the results that is given by the POCT device is accurate. So here, when we regular testing with the control material is mandatory here, and we should provide the mandatory training to all the person who is running the POCT devices, that their competency should be assessed on a regular basis. The device maintenance and calibration should be done on a routine basis, and the connectivity with the laboratory information system and health information system enhances the data traceability and patient safety. So this should be intact, the connectivity to the LIS and the HIS, and we need to be very aware of the role of the central lab, and there should be a strengthening collaboration between the central lab and the setup which is using the POCT devices. And there are certain POCT safety protocol sequence. Here, just because we are using POCT, many a times we see that the safety guidelines are not followed. We are just not wearing gloves, thinking that it is a small device, or we are just doing a prick and we don't need to wear any personal protective equipments. We don't have to worry much about the safety needs, but there are certain safety needs and that needs to be followed, like using of the PPE, applying universal precaution. We need to dispose the waste properly. We cannot just randomly discard the cartridge or the needle or the lancet that we are using. And we should also protect the privacy of health information for the patient. And the role of laboratory personnel in point of care testing is mainly with the planning and evaluation. The lab personnel will help in planning which POCT devices to incorporate in which setup. So they play a very important role in deciding this. And also they play a role in validating the performance against the central laboratory standard. And educating and certifying non-lab personnel that they are capable of performing the POCT devices, that training is provided by the laboratory personnel. They ensure that the correct sampling, testing, and result interpretation are being held in place. And they have the laboratory professional also help with the designing and monitoring of the internal quality control and external quality control programs. They help with the troubleshooting and errors, and they act as a bridge between the clinicians and the diagnostic process, thus ensuring that the lab oversight is in the patient-centered setup. So with this, we have covered the overview of the point-of-care testing devices. And now in the next few slides, I will be talking about the devices, POCT devices, which are mainly used in the biochemistry lab. So here we can see there are certain devices. The most common one that we see everywhere used by most of us is glucometer, which is done for the glucose testing. And here's the principle. If you are interested to learn, you can go back and read about what is the operating principle of each device over here. We have this iStat and Roche-Stat profile for the electrolyte analyzer. We have a device from iStat and also Cobas H232 for the cardiac marker testing. For the blood gas analysis, we have a device from the iStat and Gem Premier. And for urea and creatinine, we have NovaStat sensor. So these are the various, we can see it looks like a remote control. And here we can see this urine, although it is not in the biochemistry, but this is one of the very easily performed POCT that we do in the emergency setup or in the ward. Here we are just dipping the urine sample in the strip in the urine sample and comparing the color. And this is a glucometer. This is the ABG analyzer that we have in our emergency department. And I think this is even bigger. There are even smaller micro needle based, microfluidic based devices already in use now. So discussing about the glucometer, which is one of the most used POCT device. It is a classic POCT device, and the principle in the glucometer is based on the glucose oxidase or dehydrogenase method, enzymatic method. Here, glucose is being converted to gluconic acid, and during that chemical reaction, the electrical impulse is generated, and that electrical impulse is generated is detected as a signal, and the value is given in the device as your glucose value. And it is used, very essential to use in the real blood glucose monitoring, and it empowers the patient for self-management and insulin dosing. So we must have seen this used by many of our family members at homes who are diabetic. They are monitoring their blood glucose and adjusting their insulin doses. But we need to be aware of the variability that might arise with this glucometer, like it is induced by the hematocrit level, by the temperature, the sample volume, and the user technique as well. So the proper calibration and the training is very essential. And this is initially what was used. We use this invasive method like using a lancet to prick and then getting the drop of blood in this glucose strip over here and getting the value. I'm sure many of us have seen this device. And there was another invasive device which was used for continuous glucose monitoring. Here, the implantable device is inserted in the body of the patient, and that was used to continuously monitor the blood glucose of the patient. But this had a challenge that because of its biofouling inside, it had a very short half-life, and this device had to be replaced every other time. So because of these, they are now non-invasive method. And what I found interesting was that the glucose is now being measured in the tears, in the saliva, in the interstitial fluid, and also in the sweat of the patient. And here, if we see, this is like a contact lens which is kept in the eyes, and here are chips and antenna that are located in that device. And that chips and antenna is wirelessly connected to a device outside, which will give you a continuous monitoring of the blood glucose level. So this is how it is done. And this also is, we have glucose patch as well, where it is measuring the glucose in the sweat. But for this, obviously, there are certain challenges because you need to have the patient sweating, and patient sweating all the time is not possible. So all the devices definitely comes with its pros and cons. But these are the advancements that are happening with the POCT glucometer that we can see. Similarly, for the electrolyte ABG analyzer, we can see it is measuring the sodium, potassium, and the bicarbonate, and blood gases are measured. And these are the devices, the iStat devices, like a remote control. This is a GEM Premier, and it is essential in ICU emergency trauma and shock setting. And I would like to show a small video over here about how this is a 2-minute video because I've been speaking continuously now. Let me just show this video, and you can see how easily it is determining the ABG level in the patient. So let's have a look at this video. So the ABG analysis could be as simple as this in the bedside, in the ICU, in the emergency department.
This is an iStat handheld blood analyzer by Abbott. It is used in integrated point-of-care testing. Here under Test menu, you have 1 last result or 2 iStat cartridge. Since we will be using a new cartridge, we would select 2. You're able to scan or enter the operator ID. It might prompt you to do it again. After which we scan or enter the patient ID. Once again, it might prompt you to repeat. We then scan the cartridge lot number, which is on the package insert of the cartridge. This here is a cartridge. We will be using an arterial blood gas sample, which is in a heparin coated tube, syringe. Mixing it between the palm of our hands vertically and horizontally in the attempt to get the blood homogeneous. We remove the first few drops of blood and discard it, and add in the next 2 to 3 drops into the cartridge till the indicated mark. We then close the cartridge and insert it into the blood gas analyzer. It would take relatively 120 seconds to read the blood, to analyze the blood. And the parameters which are measured is pH, PCO2, O2, base excess, HCO3, oxygen saturation. The analyzer then stores this record, and you will be able to retrieve it manually when required.
So as simple as 20 seconds and the patient's ABG reports are made available. And we could see here. So here in this video, although this video was 2 minutes, I think it covered almost so many aspects of the content that I spoke for the last few minutes, including the PPE that was used. We saw that there was no any chances of contamination with the sample, but the person using the POCT device was using gloves. The samples were applied appropriately. The samples was mixed appropriately before keeping it in the device. The tube was heparinized. All these pre-analytical variables were taken control of before doing the actual testing. So here, so that is one thing that we need to see or keep in mind is the manufacturer leaflet or the MIFU should always be read before, and this is how all the details are given for every POCT device, and everyone who is using the POCT device should go through these MIFU leaflet or packages. So this is again for the cardiac marker testing. It tests for cardiac troponin, CKMB, and proBNP, and which is useful for MI detection and heart failure patient. And it has a rapid rule-in and rule-out decision at emergency triage, and it facilitates early intervention and patient stratification. Here, all I want to show is this is a device that we saw earlier. Here we have the manufacturer leaflet with the CD, which provides all the detail about the instrument. And one thing that I want to highlight here is the quality control sample. Many of the quantitative device that we use for POCT has the quality control sample provided there. So we need to be very careful to use this QC run every time we are testing for the patient sample, depending upon the patient load. So here are various devices. This is based on the lateral flow strip. Here, this is the urine analysis by dipstick. Here, we can just simply compare the colors and detect the various analyte like leukocyte, nitrite, pH, hemoglobin in the urine sample. And here, this is a qualitative test, but again, this can be also used to quantify as well. The same strip is inserted into a device, and based on the reflectance photometric principle, the quantity is given over here. And this is the COBAS where it's showing the quality control sample, which we need to run for every POCT device. And I just have bought here, I think everyone is aware with this POCT strip. So this is simple strip that you have with different color codes, and you will be dipping this for 10 seconds, 10 to 20 seconds in the urine and comparing it, the color with here, and giving the report as various parameters or like present or absent. And the other kit that I want to use just here is the kit that we use for the UPT test and all. The only thing that I want to highlight here is when we talk about quality control, we have it for the quantitative test. But for strip like this, we do not have quality control, right? We just add the sample here. The first line is for the test. The second line is for control. If we just see a line in the control and not in the test, we say it as negative. I'm sure we all know that. If we just see both of the lines positive, we say it's positive. But sometimes you just see one line in the test and you don't see any line in the control. We cannot report such reports as positive. We have to see a line in the control as well to say it as a positive or negative. And sometimes we see this entire kit as blank, no lines anywhere. In that case, we cannot report this as a negative test. So the line to be seen in the control is very essential. And this control line, in fact, act as a quality control for this qualitative strip. So the QC things needs to be kept in mind. So here, as we just saw with the ABG device that we saw in the video, similarly, if a patient comes with the chest pain, with the symptoms of the ischemia or ischemic chest pain, we do a troponin test on the POCT device. If the test result is positive, the patient is immediately taken to the cath lab for intervention, and we have a clinical outcome. So within 10 minutes, the patient is shifted from the emergency department to the cath lab for the intervention to be started, thus improving the clinical outcome. And here are some non-invasive POCT device. I'm sure during COVID time, we all are familiar with this pulse oximetry. It uses this infrared and red light, and the infrared light, the oxygenated hemoglobin absorbs more infrared light. So more oxygenated hemoglobin, more infrared is absorbed, and more percentage of oxygen saturation is displayed. So this is one example. And another non-invasive is transcutaneous measurement of bilirubin. So in neonates, in the, those babies who are under phototherapy, repeatedly testing for bilirubin might be traumatic. Every time we have to prick the baby. So this transcutaneous bilirubin measurement is very useful in such a time. Now, with this, the future trend is much more working towards, as I said, smaller, variable microneedles and microfluidics-based devices. So there is smaller and smaller devices being made. We can see, many of us wear smartphone as well. We can see ECG there. We can measure our oxygen saturation. These all also comes under the POCT devices. And we can see that with the telemedicine being incorporated in the health system, this POCT device plays a very important role in advancing the healthcare system overall. So with this, we have come to the end of this, my talk over here. So overall, we talked about the definition of POCT, how do we define it? What are the various name of POCT? What are the various application, the scopes? Where can we use this POCT devices? What are its strength, the advantages? What are the challenges? What are the things that we need to keep in mind when we are operating the POCT devices, especially in alignment to the quality control, the procedure, the manufacturer packages on all, and what are the roles of the lab professional and the future of the POCT, how it is going to improve the overall patient outcome. So with this, we come to the end of this talk. And if there are any further questions, I would be happy to take the questions at the end of the session. And with this, I would like to invite our next speaker on the stage. I would like to call the MC to take the lead. Thank you so much.